Hello, everyone. My name's Hill Akid. I'm the Research and Policy Manager at MedAct. I'm going to be facilitating tonight's event. Thank you for joining us. So I'd like to welcome everyone, both online and in I want to say studio, but it's just the MedAct office, hence the boxes. Tonight is an online event that's part of MedAct's Learning for Action series, which is a series of political education events that are designed to support our long-term organizing and campaigning for health justice. Um, this is the second event in that series, and as you probably know, tonight we're going to be focusing on the state of trans healthcare in Britain, and not just trans healthcare, but trans health more broadly, and asking also what could trans health justice look like? And within that kind of quite broad remit, we want to look not only at very important things like access to gender-affirming surgery and hormone replacement therapies, but also how trans health in general is shaped by social and economic determinants of health, such as housing, austerity, and of course the pervasive climate of transphobic hostility in mainstream politics and the media. And we're also going to try to introduce a note of hope and talk about what resistance rooted in solidarity looks like. As a trans person, this issue is close to my heart and also the hearts of many other staff members, many of our wider membership, and many people in the health justice movement. And many people who are in our membership who are frontline health workers who are cisgender, we know want to also push back against the medicalization of transness and how the health system kind of gatekeeps access to care. Um, so what's prompted us to kind of bring this issue to the forefront of our minds and to make it the focus of tonight's political education session is probably not a mystery to anyone, even those who aren't in the trans community or aren't in the LGBTQ plus community. It's really difficult to miss the fact that the gains made by the trans liberation movement in this country and beyond um, in the last few generations have triggered a really ferocious backlash by the forces of organized transphobia, which has intensified over the past recent years and indeed months in this country. Trans adults who are seeking gender-affirming healthcare are routinely confronted with pathologization and the slow violence of years-long waiting lists, partly as a result of chronic underfunding. And following the CAS review, the NHS halted prescription of puberty blockers for under 18s. We're also just very recently now, I think, seeing reports that schools are going to be stopped, told by the new Department for Education guidance that they cannot encourage students to question their gender identity. So lots of echoes of sort of Section 28 there that are going to affect young trans people education and lives. Of course, the recent Supreme Court ruling is also extremely prominent and can't be, underestimated. The sort of the weight that has. It's undermined trans people's rights, in particular the rights of trans women to self-determination. And we're witnessing this struggle for trans rights and trans existence happening not only in the health system but also in central and local government, in education, in fact, in every facet of civil society, from the Hampstead Heath Ladies Pond to grassroots sports clubs. And what's at stake, we think, is not kind of only trans rights and access to gender affirming healthcare and to the right to live healthy lives across institutions and borders, but also, trans health is really intimately tied to other issues of bodily autonomy. So, reproductive and abortion rights obviously spring to mind. And the attacks on trans health, in our view, are not isolated. They're part of a wider rollback of the welfare state, of access to healthcare, and of human rights more generally. So while Medac, doesn't have capacity to sort of actively campaign on everything we would like to, we think it's vital for our work and for the broader health justice movement that we educate ourselves on this issue and that we make the connections with other struggles and that we step up in the ways we're able to in our workplaces and communities to defend trans health, trans healthcare, and trans people. So we're going to hear from three really great speakers tonight, from Jack Doyle to my left, from Fae Fulconis, and from Shiraz Hussain online. And they're each going to be giving us their perspective on these issues from a slightly different angle. So huge thanks to them for joining, as well as you in the audience. I'll introduce them a little bit more shortly, but I'm just going to do a very quick bit of housekeeping before we begin. So firstly, just to encourage everyone in the audience joining us online to introduce yourselves in the chat. So if you just type in the chat box now, tell us your name, perhaps the location you're joining from, and anything else you'd like to share. Throughout the event, please do post your questions if you have them for our great panel of speakers in the chat box. James, my colleague, or possibly Nina, I can never remember which, is monitoring that chat box, and they're going to collate the questions for a Q&A session at the end. Please do keep your microphone muted, or we might be able to forcibly do that for you. But of course, feel free to have your camera on or off as you please. If you want to access auto captions, you can turn them on if you just go to the bottom right of your screen and click More, and then click Turn on Captions. They should be available. And finally, just to let you know, in case your computer hasn't, that we are recording the session. And finally, before I introduce our speakers, I wanted to just briefly remind everyone about MEDAC's Safer Spaces policy. So when taking part in MEDAC activities, whether online or in person, you agree to take an active role in creating a respectful, understanding, and kind space. So we don't tolerate any harmful, oppressive, or abusive behavior that excludes, threatens, or disrespects others, and we will remove anyone from the space who doesn't act in accordance with that. Please try to be aware of your privileges, including less obvious or invisible hierarchies, and think about how your words, opinions, and feelings are influenced, or who they might exclude or harm, and be aware of how much space you take up accordingly. We like to say that comfort and transformation do not always live in the same house, so be open to listening, learning, and take a time to examine your reactions. And finally, take care of yourself, so please take time to hydrate, move around, take a break as you need. So without further ado, I'm going to introduce our first speaker. Very excited to hear from him. Jack Doyle is a trans fag historian, tour guide, and community educator based in East London. He's a long-time worker in frontline trans and anti-racist health, immigration, and food justice organizing. Over to you, Jack.
Oh, thank you so much, Phil, and thanks for having me. I'm going to kind of wear two hats while I speak, and I'll try to keep to time, nudge me if need be. But I'm both a historian of queerness, of empire of war in the 19th and 20th centuries. And also I've spent kind of the past 10 years-ish doing frontline trans health work. I've set up several different patient advocacy groups and services, including the Spectra Trans Health Advocacy Service in London. And yeah, I've kind of seen, I think the past 10 years especially has been a really transformative period for trans people generally in the UK, globally. We are living, as Hill alleged to, in the middle of a kind of global anti-trans moral panic right now. And I do think actually the UK case has some really specific things to it that I think might be useful for thinking about building kind of health justice solidarity. So I'm going to try to speak to that a little bit. But maybe just a quick potted history of trans healthcare. When I say trans healthcare, obviously we all want to take a broad idea of what health is. So healthcare for trans people very much includes access to food, housing, safety, freedom of movement. But when I'm talking about trans healthcare, I'm mostly talking about transition-specific care. So that the kind of idea of transness as a kind of medical category comes to us from the late 19th century, comes with the rise of sexology, psychiatry, psychology, and the kind of Western European push to categorize and medicalize and kind of regulate gender and sexuality. And we see this in medicine, and we also see it in kind of colonial policy. So, pretty much right around the time like homosexuality becomes like a diagnostic category. The British Empire also exports anti-sodomy laws and laws that criminalize gender nonconformity by sort of Western standards across the empire. I'm thinking like 1885 here. I think that's kind of no accident. I think this kind of colonial push to regulate and control people's gender and sexuality is very much kind of a late stage imperialism sort of phenomenon. And I think that's always really important for me thinking about this. Probably the earliest instance we have of kind of like formal medical transition as like a part of a health institution is the Institute for Sexual Science in Berlin, which is set up in the 1920s by a guy named Magnus Hirschfeld, who probably people have heard of. He was a cisgender gay man who was advocating for kind of queer and trans people's legal rights and especially trans people's right to access transition and medical care. So some of the first kind of gender affirming surgeries that we know of, like modern gender affirming surgeries, people have been like doing gender affirming surgeries for thousands of years in various ways. Speak to me after class if you want any details on that. But yeah, kind of the modern, kind of gender affirming surgeries were largely pioneered at the Institute of Sexual Science. And as we're seeing, you may have seen recently, because it's popped up again recently, if you've seen any of the pictures of the Nazi book burnings in the early 30s, those burnings are of the Institute of Sexual Science. So again, these photos have kind of popped up again recently because we're living through the rise of fascism again. And that parallel is very much there, that trans people, especially also Hirschfeld was Jewish. So was, those people were kind of being deliberately targeted as some of the first victims of the Nazi regime. Trans healthcare has never been people's kind of favorite, thing to support really. In the UK, though, so in the kind of US, across Western Europe and in the UK, trans healthcare kind of lived in different bits of medicine, endocrinology, psychology, um, and often people who were able to access kinds of medical transition, unsurprisingly, were wealthier white people. Um, but there's also a long history of trans people supporting each other through DIY, do it yourself, kind of outside of formal medical fields, including people like training to become doctors and nurses. And, one of kind of trans health pioneers in this country, Michael Dillon, he was a trans man who trained as a doctor in the 1950s. He performed bottom surgery on Roberta Cowell, who was one of the first kind of publicly out transitioning trans women in the UK. So again, a sort of case where cisgender providers were not willing to do that. And so Dylan, as a medical student, did that for Roberta Cowell on his kitchen table. There's a long history of that alongside kind of a history of, white, wealthier trans people, kind of visibly medically transitioning. Um, uh, the UK medical transition kind of got started with gender clinics in the 1960s. That system was founded and kind of integrated into the NHS through kind of combining endocrinology, psychiatry. The guy who set up the UK gender clinic system, which still basically functions as it did in the 1960s, was a man named John Randall. And he was very explicit that what he was doing was a eugenicist project. That was a word that he used, eugenics. And he was very much interested in kind of creating trans people to be sort of assimilated, cis-passing, sort of productive members of white middle class society. So that legacy is still very much with us. The UK, we still operate what it's called the gender clinic model of care. Most countries that offer gender affirming care today, including parts of the US where it's still legal, operate on the informed consent model of care these days, which is basically putting trans people at the center of our own decisions about our bodies. The gender clinic is a very violent psychiatric institution that requires people to go through these various rounds of psychiatric assessment to be diagnosed with gender dysphoria. So just briefly to give you a sort of idea of where things are today, Hill mentioned the wait lists for these gender clinics, which are vast. What I will say is a lot of trans people even don't really know this, but the gender clinic wait lists are not like 4 to 7 years, which is what the NHS says. They're closer to 30 or 50 for a first appointment based on how quickly they're processing referrals. So functionally, there is no trans healthcare through the gender clinics on the NHS. It just doesn't exist. Functionally, there is no transition care for young people. There are other ways to access care through the NHS, but I would say the majority of trans people in the UK who are medically transitioning right now are either going private or are DIYing. That's kind of where we're at. Um, and also, actually, it's not an underfunding issue, the reason for these wait times. Weirdly, gender services are some of the only services on the NHS who've had their budgets dramatically increased during like the austerity years. Um, my personal view is part of the reason why these wait times exist is that pretty much everybody who works for an NHS gender clinic, not everybody, but like a lot of clinicians who work for NHS gender clinics also work in private care. So they basically are collecting a second paycheck, you know, exorbitantly raising prices. Prices have pretty much tripled over the past 10 years for things like top surgery or getting hormone replacement therapy. So there's kind of no financial incentive basically for the system to be reformed. And where we're at right now is I think people don't understand the scale of the crisis, and I don't want to catastrophize. I should also say that I do feel very hopeful in more than I did a couple of years ago about where trans communities are in terms of how we're organizing our own care. But I do think we are probably going to see the formal end of like hormone therapy in the next couple of years being offered on the NHS. Functionally, that's been taken away from young people. I think we're probably going to see the same for adults. Yeah, what I will say from my many years of working kind of frontline and helping other trans people access healthcare is that, yeah, as Hill mentioned, like, poverty, employment discrimination, housing discrimination are huge factors in whether or not trans people can access transition. I was able to access medical transition basically because when I started medically transitioning, I was doing a degree at Oxford and I had a like decent paying job as a journalist. But I still, even years ago when healthcare was a lot more accessible, like a lot of people do now, I went to France to access my top surgery. Um, and yeah, I think things are not in a very good place. But what I will say is that, yeah, we're in, I think things, because of the scale of the crisis, I think trans communities are really activating, and so are allies, especially within the healthcare profession. So I'll leave it at that. Maybe that's my rant.
Thank you so much, Jack. That was incredible. Not only that you did it all without notes, just sweeping history. Yeah, just some real depth of knowledge. I learned a lot, and thank you for correcting me on the funding issue.
No,
That
a
was
lot of people don't know. It's
interesting.
okay. Yeah, yeah,
Yeah.
but yeah.
I'm sure that that will stimulate lots of audience questions as well. So just a reminder to people that you can submit questions for any or all of our speakers by putting them in the chat box, and we will collect them there for the Q&A at the end. I think there was a nice little segue there. It seems to be a running theme for our panel about getting healthcare in France. So it moves me on to our next speaker, Fae Fulconis, who's a football player, occasional writer, PhD dropout, and French teacher. Over to you, Faye. Great bio as
Sure,
well.
yeah. Hi everyone, so thank you so much for having me. So today I'll be talking a bit more about my personal journey through getting hormones, because I think it's actually quite symptomatic of the recent developments. And I also have the chance of being French, and so I have French healthcare and the French system, and so I can also talk about that as a comparison possibility. Also, it's strange for me to not be the one speaking about theory for once. I think it's refreshing. So basically, I'll talk about mostly my like the medical side of my transition because the rest is private, of course. So I signed up on the wait list for the GIC, the Tavistock one, the infamous, in January 2021, I think. Yes, January 2021. And so that basically was the only option that was offered to me by my GP at the time, who told me that it was my only option for accessing any sort of care for gender dysphoria, for like hormone HRT, etc. And so I was told the wait was going to be about 5 years. Obviously, like 2, 3 months later, I was like, this is impossible. I'm not doing this. And so at the time, I was very not talking to my parents. I was very estranged from France as well, so I didn't even consider it an option. Um, and so basically, also, if my doctor had told me that I could have joined whatever it was called, Trans Plus, I missed the cutoff by like a month. Um, I decided to basically go private, and so I went through the steps to go with gender GP. It was like kind of expensive and also like, a bit extortionate in the practices, but it helped me at least get a way into the system. And then I got hormones from them. It was like basic gel, etc. And then I decided to transfer to the NHS through some crazy loophole that people used to be able to do by going through GP at hand, which is the like online service, requesting a specific doctor who was a trans woman, who basically just helped trans people get bridging prescriptions, which the NHS at the time had the obligation to do and failed to do so in most cases. You would go to doctors and they would be like, I'm not competent to do this. And then they would, which is ridiculous because obviously they're not competent to actually do anything because their studies are 7 years long where they spend a month on each thing. So it's like they are not actually competent to do most things that they do. And so hormone, like prescribing HRT is really simple. I mean, you literally just the doses, everybody, the research is so massive and it has been done in most countries. There's like so much research that they could just like every trans woman knows this, every trans man knows this, every non-binary person who's taking HRT knows this. You spend a day on Reddit and you know everything. I mean, it's not that hard.
I am an endocrinologist, actually. Yeah. No, not
Exactly.
yeah.
Where was I? So the loophole. And then obviously GP at hand collapsed. It started going separating the private from the public because the peasants can't have the same healthcare as the bourgeois, of course. And the NHS started cracking down on any sort of actually even fired the doctor who was doing this. Didn't fire her, but pushed her out. And gender GP started being not what am I saying? GP at hand started being much more rigorous, and I've heard a lot of cases of non-binary people who got their meds denied, their repeat prescription that they've had for a long time, and then they were like, "Oh, we need to see in person," and then asking them for actual GIC information. And that's when I kind of decided. Also, I realized that I wanted bottom surgery, which is ironic because now I don't want bottom surgery, and I ended up getting FFS instead, which why not? But I really, really wanted it at the time. I was like, I really need it. I talked to my parents. I was like, can you give me money? They were like, no. I was like, okay. And they told me really like, you should go to France. Like, it's fine. Like, and I didn't know at the time anything about the French health. I mean, I knew about the French health system as in it was much better than the NHS. So hard. And that, but I didn't know about the trans side of things. And I always had in my mind, oh, France is more like transphobic than the UK, it's not going to be easy, or it's like much more like complicated. But I knew I could get it for free. And so, and I assumed the doctors weren't as good and etc. etc. But my parents really were like, you need to do it there, it's free. Like, why would we give you money so you do it in the UK where there are like 5 surgeons? And then digging and digging and digging, I realized that like every single big city in France has a surgeon who is specialized in either urology, gynecology, or plastic surgery who does it. The wait lists are reasonable, and there's an entire process that France actually set up that's really comprehensive, really interesting. I'm not going to get into too much detail, but basically we apply for a specific category that used to be a disability that they kept under the file because it allows us to get everything for free on the French healthcare. Because the French healthcare, contrary to feelings, is not entirely free. It's 80%. It's not 100. And so it allows us to get 100% on everything. So you apply, you say, I'm trans, I want to do these things, these things, these things, these things. Your GP signs it off. But also GP in France are just like, there are doctors that you go and see. It's not like here where you have to, they are all independent. And so I walked in the first day, I was like, I need this done. It was done the same day. She was like, do you want me to prescribe you hormones? I was like, well, why not? So I got hormones prescribed in France. Even progesterone, which the NHS refused to prescribe to me. It was all free. And I think it was before I got the thing signed. So I think the consultation cost me like €7. I have also happened to be lucky and have 2 trans siblings, and they also both got hormones on their first visit. The thing is, you just need to know the doctors beforehand because obviously they're transphobic assholes who are just going to be like patronizing and etc. But if you have a friendly doctor, they can prescribe hormones the same day. And I went through the system to get bottom surgery, and obviously it was it's a process. It's very complicated because of bureaucratic hell, but it's being reformed as well. And now you don't even need, you used to need consent from a psychiatrist, a doctor, like GP or endocrinologist, and a surgeon who was going to practice, which is obvious. And they even removed that. So we don't need that anymore. And the psychiatrist visit is not like here where you need to book like 10 appointments and they charge you £2,000 for it. It's like you go to a psychiatrist, you speak for 10 minutes, they're like, fine. So the system is very like is much looser. It's done by hospitals. It's much more decentralized. It fits the needs of the people. The longest waiting time you can get is about something like 5 years with the best surgeon. And then but you can go all over France. You don't even have to be there are no catchment areas in France. With some surgeons, it's like 6 months. And yes, so I ended up being on all these wait lists, which I still am on, and just deciding whether I'm doing it or not, which right now is no. And also, I know have very little time left, but I'm fully doing DIY, and then I'm just getting my hormones from France and giving it to trans people. So, because injections are the way to go. If yeah, injections are just better in every way. And my final words. Yeah, I mean, even if you have to pay, France is still significantly cheaper because the system is made in a very particular way, and there's the best surgeon in Europe who, for anything that's not like bottom and top surgery, but for anything more cosmetic, is very cheap and very good. And his name is Quentin Cassemiard.
Little plug at the end.
Yes, exactly. I mean, I
Answers
have
are
to,
available.
so.
Thank you so much, Faye. I'm sorry to cut you short.
No,
I've listened to you much more. It was fascinating to hear your story, and a lot of it was very relatable for me as someone who's also struggled and fought through the British system and also just not understood how it works and spent a lot of my medact pay packet on care. So yeah, thank you for sharing. And yeah, again, just a reminder to our audience, if you have questions for Faye or any of our panel, just pop them in the chat. We're now going to move to our third and final speaker, Shiraz Hussain, who is a socialist and a member of RS21. She's very concerned about the hostility toward the trans community currently being whipped up by anti-trans activists, sections of the media, and some politicians. So I think TJ is going to mute us, and over to you, Shiraz. Thank you.
Okay, thanks very much for that introduction. And I wanted to begin by telling you a little bit about myself, because it casts light on why this is so important to me. I'm an older transgender person. I grew up in the 60s, and I can tell you I became aware that there was a problem with my gender, as I thought, when I was very small, very young. I immediately knew there's something wrong here. I just don't feel right. I feel that I should be a woman, or I should be a girl. And the problem was that I believed, and I continued to believe until the age of 15, that I was the only person in the world. I thought I was the only one in the entire world, and I thought there was something terribly wrong with me. And this caused me very deep shame right throughout my life until I started to know that there were others like me. That was the first time I thought at the age of 15 I came across things that were being talked about at that stage. That there were things called sex changes, that there were people called as it was then transsexuals, and that there were people called transvestites and all this stuff, which I'd never heard of before. It simply, that kind of thing was simply never spoken of at all. And it's worth asking why I felt such deep shame, and the answer is not actually difficult to find. We're talking about the 1960s, and the 1960s, as I remember only too well, was a time when misogyny was not even recognized as misogyny. The word sexism didn't even exist in that time. It came about much later. And certain views of women were around, and certainly the way that women were portrayed in films, in popular narratives, was, I think, not something that anyone would have wanted to identify with. And neither did I. And I also bought into this notion that there was this classification, and that, society seemed to believe that men were worth much more, and men got to do all the interesting things, and there was something really special about being a man. So why on earth did I want to be a woman? And these messages come through, and there was no one to challenge them, and I certainly didn't challenge them, and I suffered with this sense of shame all my life. And then it was really, I was very, even once I knew that I was different and that there were others like me, I was very confused. I was very unsure of myself. And it was only much later in life, finally, after having been in various therapies and not finding any solution, talking therapies, analysis, God knows what, I got to the age of late 40s. And at that point, it just came to you just one night out of the blue. Do you know what? You're transgender. You are transgender. And that was just such a revelation to me. And the moment that came into my mind, I thought, well, I have now a very clear choice. I can live as a coward. I can live not in my truth, and I can live and die as a coward, or I can actually do something about this. Enough. And within a very short time, of course, I said, well, let's do something about this. I don't like the other option. So I went and saw someone at work who I just said, I'd quite like to talk to you. I understand you're a diversity counselor. I've got a bit of a problem. I'd like to talk to you. I don't know if you can help me, etc., etc. And I ended up talking to this diversity counselor, in the process of which I just broke down in tears in front of her, because it was just such a lot of pent up feeling that was released by the notion that I could be accepted, and that there was a different pathway open to me. And I proceeded. I did my transition. I transitioned around the age of 50, and it was just such a revelation. It was like, from being a very diffident person, from being someone who didn't have much to say to anyone, I just couldn't stop speaking, because it was all coming out. Everything I wanted to say, everything I'd held back, everything I hadn't expressed, everything I'd been afraid to say, it all came flooding out. So it's in that context that I'm beyond angry about what is happening now to our community, to the community of trans people, and that there are forces out there who want to set us back 20 years or more and reduce these poor young, especially the young trans people who are just, who have really, on paper, got all the help that, a lot can be done for them in terms of treatment, in terms of surgery, in terms of hormones. It's all there for them, but now it's being denied. It's being denied in the current context. So let's talk about the current context. Medicine happens not in a void, not in some kind of pristine space that isn't touched. Medicine happens in the context of societies, in the context of cultures, in the context of political views. All these things impinge on medicine, and they affect it. Health workers are not free, typically, to do what they want to do. They are bound by the pressures, especially of politics. Let's talk about the current moment. We have three big problems. One is the caste review. The caste review has had immediately a very bad effect on young transgender people. Then we've had the Supreme Court judgment, which started talking about something called biological sex, or a biological woman, but they leave this very problematic term undefined. We're not told what aspect of biology is involved here. We're just told it's common sense, but that notion of common sense is one of these notions that just falls apart when you try to pin it down to what it's actually saying. So that is biological sex. Then we have these strange people called the EHRC, who seem to have developed some kind of fixation on toilets. Toilets have suddenly become very, very important. Public toilets. Who knew that a public toilet needed to be such a site of contention? Back in the 1970s, I remember in Victoria Court Station, there was a unisex toilet, and it carried on quite happily. It wasn't in the slightest bit controversial. No one had a single thing to worry about. No one said anything against it. It was simply not an issue. Suddenly, in the context of transgender people using what is considered to be the wrong toilet, suddenly unisex toilets are considered also not a solution. They're considered a threat. And this notion of threat, we're left wondering, in what way are we threatening? Who have we threatened? What's the problem with our existence? This notion, which has been taken up by our Prime Minister, now talking about, who suddenly got very exercised about possibly transgender female patients using the toilets of their appropriate gender in a hospital, and saying, no, that shouldn't be happening. They should use the male toilets. The Prime Minister felt the need to say this. I don't know why he felt the need to say that, but there it is. Now, in this context, I'll take these points in turn. The first one is the impact on young transgender people, which I think is just simply disgraceful, what's being done. We have known about puberty blockers for quite some time, and in fact, they don't originate in use. They don't originate with helping trans people to avoid, to postpone puberty. They originate, as anyone medical knows, with young boys who go through puberty much, much too early, at a very young age. And to avoid certain problems, these medications have been in use for a very long time without any controversy at all. And no one has raised any concerns whatsoever about the age of the patients. Suddenly, when it's transgender young people, it becomes a huge issue. It's some terrible threat. Two things. One is suddenly people seem to be and appear to be and claim to be very concerned about the welfare of these young people. And but these young people are presumed not to know their own minds for some reason, even though they may be teenagers. It still seems that they don't know their own minds. Now, legally, this is very strange. because from the age of 10 in this country, you can be hauled before a court of law and you can be prosecuted on a criminal charge from the age of 10. From the age of 16, you can join the army, you can get married, you may give your consent to a sex act. But suddenly when it's transgender people of the same age, suddenly they're not competent, suddenly they're not to be trusted, suddenly their feelings are to be set aside, they're to be offered counseling. What is this counseling meant to achieve? Is it meant to counsel them out of being transgendered? Is that how it's supposed to work? Is this conversion therapy that is being pushed here? What is going on? What is this nonsense? And we know, so what is the source of this other than an unreasoning prejudice against transgender people? It seems transgender people are to be portrayed not as people, but as a problem to be solved. And of course, when a group of people is so classified, then the impact on medicine is, as we have seen in the past with gay people, is that medicine is co-opted into a role not of care, but of being a gatekeeper, an agent of social regulation. Suddenly, these people are not patients to be treated or to be helped. They are there to be regulated. They pose a threat. Similarly, this notion of biological sex, if you try to analyze it, well, what aspect of biology is involved here? Are we talking about reproductive apparatus? Are we talking about gametes? Are we talking about hormone levels? Are we talking about the external appearance? Are we talking about physiognomy? It's worth noting that this kind of hysteria that's being whipped up around people using the wrong toilet has mainly impacted on what are called gender non-conforming women. These are women assigned female at birth who are women in every sense, but who don't have a physiognomy or facial aspects that people consider feminine enough. And there are some horrible examples of people who've been humiliated, called out, interfered with when they're trying to use a public toilet, including, I believe, one of our Scottish members of parliament, or member of the Scottish Parliament, who has been left in a situation where she can't go and use a public toilet unless she takes another woman with her who can vouch for the fact that she is actually a woman. And this is the harm that is carried out. It leads to all kinds of humiliation for women. There's a very strong impact here where gender is regulated in this manner. And gender is considered problematic and something that needs regulation. And sex is meant to fit into a strict binary, which it is not. We have intersex people who are, I believe, about the proportion of intersex people is the same as the proportion of people with red hair. Now, no one seems to be very worried about the presence of people with red hair in the population. It doesn't seem to pose any problem to anybody. Somehow this other section of people who have the same statistical weight in the population, they're being ignored. They're saying, oh, well, they're so rare that they don't really exist and we don't really need to bother about them at all. Now, Johns Hopkins, the sexologist who studied all these matters of physical sex, would disagree with that because they are on quote as saying, initially, they were simply sexologists. They had no interest in any political matters. They said, and I believe I quote exactly this, they said, there is no physical characteristic or set of physical characteristics that will enable us to reliably carry out binary sexuation. In other words, it's just too problematic and you can't define a biological woman or a biological man without either excluding people who might have thought that they were women or men, or including people that you don't want to include. It's simply impossible, which is where the origin of the separation between gender and sex comes from. It does not come from some kind of ideology. It does not come from some kind of wokeness. It's nothing like that. That is the nature of the problem. And
I'm gonna, sorry, Shiraz, I
sure.
couldn't, because you're on Zoom, I wasn't able to give you a 1 minute warning.
Oh, right, okay.
Are you able to wrap up?
Sure. And all this, in closing, I'm just going to say that there's a very clear example from a very clear parallel and a very clear connection between misogyny and transphobia. And we should not accept people saying that, claiming to be feminists and saying that they are against trans people. Because the central plank of feminism is that a woman is not to be defined in terms of a reproductive apparatus. She is not a walking uterus. She's not a walking womb. She's not a walking set of fallopian tubes. She's a woman, a human being. And this is where I think we need to remind ourselves that the business of medical care is for all people, all humans, and that all humans are of equal humanity. Thank you.
Thank you so much, Shiraz. That was really beautiful in terms of both sharing your personal story and the incisive political analysis of where we're at and the kind of politics behind it, including that end note of the misogyny at the root of transphobic hatred. So yeah, again, I think huge thanks to all our speakers. I could have listened to you all speak for another 10 or 20 minutes each. Sadly, we've kept the event tonight to a tight 1 hour, and I do want to give time to pose some of the questions that people have submitted here to our panel. So we've had quite a few, so I'm going to only be able to pick a few. I've got I'll say maybe 3 questions, and then I'll come to the speakers in turn to kind of contribute to the ones they want to, and then if there's time, there's a few more questions at the end I think are more specifically directed at some of the speakers. So the first question was someone's commented, many NHS trusts have strong trans allies, but government policy often sidelines trans voices. So how do you think trusts can effectively support trans people despite these limitations? So a question about kind of maybe, I suppose, sort of on the ground level, front line sort of resistance despite the wider climate. Then a second question about how can trans people, trans women, and non-binary people organize together? Oh, sorry, how can trans people, women, I guess that maybe includes cis women as well, and non-binary people, all marginalized genders, let's say, organize together to improve gender-affirming care as our rights come under attack? And maybe that I'm not sure if the speaker was thinking, reproductive rights for women as well, but that may be. So that's the second one. And then I will just go with. Here's another interesting one. Based on the history of trans struggles, do you think there's more potential for health workers, who are a majority of our audience, to organize on the question of trans health within unions or as separate pressure groups? So I'm conscious that our panelists don't have notes from taking the speakers, but hopefully I can jog your memories. Do other people in the room want to come back on either or both of them?
I can speak to the bit about NHS trusts and maybe a little bit the last question too, which is, yeah, I mean, doctors and advanced nurse practitioners can prescribe hormones, which I think is like still really, really crucial. Faye talked about it earlier. It's called a bridging prescription. This is sort of a loophole in the NHS system, which is that you can get prescribed hormones directly from your GP while you're on a gender clinic waitlist. How long that loophole is definitely under pressure, and I don't know how long it's going to be there for. But I think that's how we've seen that work in practice with GPs and nurses who are willing to prescribe, is that actually at a local level, it can work really well. I think the problem historically and presently is that often if a GP is willing to prescribe, all of the trans people in the wider region, like the south of England, will go to that person and the practice will kind of get overwhelmed. But what's been working, for example, in London recently, is I'm actually not even going to say the practice name just because I'm still we do have to be quite careful about how we share this information, but there's say one practice that is sort of a hub point across a whole borough, and they can kind of be a sort of specialist point of contact who can help advise other GPs across the borough about how to prescribe. So it's done quite locally, but also it means that trans people don't have to change GP. They can stay with their GP, and their GP can be resourced on a local level and with funding kind of within the trust. So I think that's quite good. And I think, people organizing, I would say doing it within a local level like that is effective and works. It's maybe making your practice or your space a place where people can come as a sort of specialist point of contact, and that helps encourage people to feel more resourced to prescribe, basically.
Thanks, Jack. Did you want to come back on anything, Faye?
What was the second question?
The second one was about how trans people, women, and non-binary people can organize together to improve gender-affirming care as our rights come under attack.
Yeah, I think I can definitely talk about this. So I think we've been doing this for a long, long time as trans women, trans men, non-binary people, etc. To we've been sharing a lot of information about which surgeons are good, which surgeons aren't good, which GPs are good, which GPs aren't good. Um, that's, I think, on the more practical aspect. I think it's just sharing, creating community, creating data banks, etc. And then I think in the broader sense, as like marginalized groups, I think that what we really need to be fighting against again is the patriarchy. And I think it's all boils down to that, because what we have right now, the discourse in the UK is the famous triangle of savages, victims, and saviors. And so it's basically seeing cis women as victims, certain cis men as the saviors, and then the deviants as um, as savages. And basically, what I'm present to is that the men who actually commit sexual violence, the men who are actually perpetrating sexism, etc., are completely absolved. And then there's this general idea that men are dangerous that's just spreading around, and that men are dangerous because they have penises and because they can control their penises, basically. But the men who are also sharing, like who are also benefiting from this, are the more upper class established. It's always been like this anyways. It's always been the upper class who have been saying the lower classes are dirty and rapists and etc. to justify anything. And so right now we have this sense of like any person who is not conforming, be they mentally ill, or be they gender non-conforming or etc., are seen as a threat. And then the poor white cis women under attack are going to the old white men for protection. And so I think that what we really need to do is, well, it's our body and our choice transitioning. I think my body, my choice doesn't stop at abortion. First of all, it also includes transitioning. And I think we really need to, again, like focus our fight against the actual problem, which is the same system, the old white men in power, and not fall for their lies and not fall for their deception of saying that men are inherently like bad, because it's just not true. It's the system that's wrong, and it's the system that makes certain men um, like that perpetuates the sexual violence and the sexism. It's not the fact that just inherently men are like this. And I think that's what people are trying to push. And that's also what the reactionary conception of society comes from with, that's what the gender criticals, or the TERFs, are defending, is an extremely reactionary conception of society. So that's
Definitely. And as a sort of trans masculine person, something that can hold you back a long time from sort of transitioning, because you're like, oh, why am I wanting to like kind of, take part in this privilege and this awful inherently toxic system. I've got two questions very quickly I wanted to pose because we've only got 4 minutes left. So I just wanted to, there's some quite specific ones that maybe people in the room can speak to for 1 minute, and then I've got one for you, Shiraz, before we're gonna have to wrap up. So Faye, this one I think is for you. Do you need to be a French citizen to get HRT in France? And then Jack, maybe you can answer this question, which is, what should we do if NHS hormone therapy is suddenly denied? My partner and I use Gender GP slash NHS shared care, and we worry about losing access, especially for my trans femme partner. Have you got any advice on preparing for that? Yeah.
DIY. So you do not have to be a French citizen. So the best thing to do is go to university in France, which will cost you a grand total of 150 euros per year. You don't even have to speak French. Just go to like English literature or something where you don't need to speak French. Sign up for a French uni, move to France, do your job remotely. And then once you're a uni student, you automatically get French healthcare. And once you get French healthcare, like that's the thing with France, is that France loves its categories, but it's like once you get French healthcare, you're considered the exact same as a French citizen. Once you transition at the state in France, you're considered as, like, I'm considered a cis woman in France, which is great. Like, and also it has its drawbacks, as in I can't use my own sperm to have children in France because I'm considered a cis woman and cis women don't have sperm. So anyways.
So that's simple.
Yeah.
Yeah.
And yeah, regarding the question about if we do lose access to adult hormone care, yeah, again, I don't want to fearmonger, but I do think it is a good time for trans people and also allies to sort of get prepared. Something I'm recommending people do is reach out to like 4 or 5 trusted trans people in your life or cis people who are on hormone therapy. A lot of cis people are. I've gotten testosterone from many nice middle-aged cis women. Shout out to them. Big fan. But basically, anybody who's on hormones, because that will impact cis women too and cis men. Reach out to 5 people and try to kind of make a bit of an action group where you ask people how they know how to get hormones, ask them where they're getting their hormones currently, and try to make a list between all of you about maybe 3 or 4 kind of backup options because we all, as Faye mentioned, from like Reddit and stuff and like just being a marginalized person navigating healthcare, we actually have a huge amount of knowledge and expertise and connections. You will definitely know more routes than you think you do. And also, get familiar and comfortable with DIYing and with harm reduction. Spectra, where I used to work, runs DIY harm reduction online courses, which I think cis allies can come to as well. Because I think, a lot of us already do DIY, and it's not illegal to DIY. I should say it's illegal to sell testosterone because it's a controlled substance, but otherwise you're good. Just get familiar with that and speak about it in a harm reduction way, but also not in a stigmatizing way. A lot of people are like DIY. God. Like it's really normal way to get healthcare.
It's even better in many ways.
It is, in a lot of ways, yeah.
Yeah.
Thank you both. I wanted to, sorry, there's loads of questions we haven't had time for, including really interesting questions about trauma and also requests for resources on, the history of gender affirming care, but also practical resources for GPs. What we will do is send out a follow-up email with some resources to everyone who registered for tonight's event. I just wanted to go to Shiraz for one last question, which I'm going to put you on the spot with, and I have full faith you'll speak to you. The question was, how do we stay hopeful when we're working on health inequalities, and it feels like it's making no difference?
Yep. Okay, well, that's okay. Am I on?
Yeah.
Yeah, okay, yeah. Well, that's not actually a difficult question to answer. It is, it's been well known for some time. It's been said by someone who was actually a conservative speaker, Edmund Burke, that when bad mind combine, the good must associate, and we can adapt that to a Marxist point of view, which I'm a socialist. And the way to deal with these feelings of anguish, these feelings of depression, these feelings of being under threat, these feelings that the whole world is against you, is to combine with others, get political, join a group. Regardless of your politics, we hope that your politics is at least progressive. It's even better if it's revolutionary. Join a group, and you suddenly find that you're making friends you never thought you'd make, and that you are making connections, and suddenly you don't feel like a small and isolated person anymore at all. Suddenly you feel empowered. Suddenly you have hope where there wasn't hope. So it's quite an easy one. We are encouraged to think in terms of atomized individuals by liberalism. And that is the big flaw in liberalism. It posits everybody as this kind of atomized individual who's completely responsible for everything that they are doing and everything that happens to them. Socialism thinks in terms of, yes, okay, but where are these feelings coming from? Why is this person anxious? Why is this person in fear? Well, who put them in fear? And that's really the solution.
Yeah. Sorry. Thank you so much, Shiraz. That was a perfect ending because I actually had TJ, my colleague, saying, or someone writing, Don't forget to do a membership ask at the end. So really segued in beautifully. But yeah, I just want to say huge thanks to all of our speakers. It was really like, honestly, there was so much we didn't have time to cover because this issue is so multifaceted. But you know, I learned a lot. I also felt, you know, moved and inspired. I hope our audience did too. I think from the level of engagement, I can say they did. So yeah. As Shiraz was saying, get organized, get part of a collective. Please join MedAct if you're not already a member. And we'd, you know, especially encourage you to consider that or consider making a donation if you're able to. We're a member-led organization, and it's our members who shape our work and drive our campaigns forward. So to grow the movement for trans health justice and health justice more broadly, that's something we're trying to do is to grow our membership. And by joining, you become part of a collective that's working to challenge injustice in healthcare across the board and to build a world rooted in care, solidarity, and liberation for all. By all means, drop us an email if you've got any feedback on this particular event or if you had more burning questions. Let us know if there are other topics you'd like to hear about in our political education series going forward. And if you want to join the political education working group, I don't know how you do it, but you can do it. Maybe my colleague will drop a link in the chat. Look out for the follow-up email, which will include links to probably how to join that group and also the resources that our speakers have mentioned and questions we didn't get time to answer. And finally, yeah, if you would like to, we do invite our audience to sort of stick around and chat a little bit further. We're going to be going to small breakout groups just to offer, you know, reflections, learnings, to talk a bit more, to connect with each other if you'd like to. So just please stay on the call for that. But otherwise, if not, then thanks again for coming, and we'll see you soon.